I know people might think, oh, well, what's that got to do with occlusion? But honestly, occlusion, if it isn't part of your treatment planning, then what is the point?
So worn teeth in occlusion are, by definition, in the wrong position.
Absolutely. Worn teeth in occlusion are often in the wrong place. Put them in the right place, a lot of the time you've got your treatment.
When you're palpating the muscles, don't just press them like lymph nodes, right? Don't just feel that they're there and move on. You know, actually get the patient to bite together, feel the might of those muscles, feel the size of those muscles, because they inform your occlusal risk. And you also get some information on the general health of the occlusion.
This one did actually surprise me, and I don't know if you're gonna have this one, but you kind of helped open my eyes to this one. And that is are not 100% accurate. Can I say that one of the tools that helped me is you?
You calling me a tool?
One of the best tools ever found.
Occlusion has become one of those elusive things that we all yearn to understand, but we can't make sense of it because the textbook and what dental school taught you just makes no bloody sense. Well, that's where me and Mahmood come in. We love to break down occlusion. And for this episode, it's a really fun one actually, right? I tasked Mahmood to come up with 5 concepts or ideas or philosophies or teachings or protocols or any of the above that really helped him make sense of occlusion or really unlock something in his brain or just blew his mind. I also came up with 5 of my own, and we didn't tell each other which ones we were doing. And importantly, before we recorded, we didn't exchange notes. And so whichever 5 Mahmood picked was his and 5 that I picked would be mine. And I thought there'd be at least 1 or maybe even 2 mutual ones. And so I thought that maybe we'd have 6 pearls for you today or 8, but actually we have 10. We ended up picking 10 unique pearls, and that kind of highlights how we all learn differently. So the ones I picked were instrumental in my understanding of occlusion and my progression as a student of occlusion. And that, by the way, never ends. This episode is for everyone. Like, if you're a student, you're going to gain so much because we talk about our journey and how we found occlusion so confusing at the beginning, and these 10 things that we will reveal made it more tangible, and we're going to share that with you. Now, if you're more experienced, a lot of it will be validating, but a lot of these ideas will be aha moments for you as well. Or maybe you'll start seeing them a little bit differently after this episode. Make sure you don't miss all 10 of these pearls. Speaking of pearls, this is a PDP episode, so I'm going to give you your protrusive dental pearl. It's one I'm borrowing from our good friend, Dr. Michael Melkers. Had the pleasure of teaching alongside him and Mahmood at Bulletproof Dentistry in Birmingham just a few weeks ago. This is our hands-on occlusion course, Daily Occlusal Protocols. And so Mike's role was to share cases and talk about joint position and how to use the leaf gauge properly. But throughout the day, as Mike does, he was giving so many pearls and gems in terms of communication and case presentation. And one just really stuck with me, and I urge you all to implement this tip I'm about to give you, especially if you're early on in your career. Now, most of us are taking photos, right? Now, if you're not, don't worry, there is the 21-day photography challenge on the Protrusive Guidance app. In 21 days, just 5-minute videos, you can take lovely, consistent clinical photos. So check that one out, and there's no more excuses not to take photos. Now, as you take more photos, you build your portfolio. You're able to communicate with your technician better, you're able to communicate with your patients better, and to your mentors. But this really great idea of what to do with your photos was shared by Dr. Michael Melkers with the delegates on the course. So get this, create a PowerPoint or a Keynote presentation, and any key before and afters, or even peri-operative photos that highlight something, that show something. For example, cracks inside teeth. You know, we take photos of that all the time. And I'm sure you've got some good photos of cracks, and if you don't, borrow mine. By the time this episode comes out, in the consent form exchange on the Protrusive Guidance app, there will be some wonderful photos of cracks I've taken throughout the year, so you can borrow mine. But essentially, anything that you think will help to communicate a point to a patient, you start making a Keynote or a PowerPoint presentation. Now, I might be teaching you to suck eggs, but here's what I've been wrongly or annoyingly doing all these years, is I've got like these labeled photos in a folder, and I kind of find the one I need, and I double click, and I show the patient. But it made me realize that that's very clunky. It's very clunky to go and find an individual photo. It's much nicer if you put this all in a scrollable Keynote or PowerPoint, because you know what, and this is a point that Michael made, is that when you open the Keynote and you start scrolling and you're looking for the bit, and the patient's seeing all this, their eyes light up. They're like, whoa, that's a lot of photo of teeth. And it actually builds credibility that, wow, this dentist has so many photos of different scenarios. And as you're scrolling through all your veneer cases, overlays, and then you're finding any complications, etc., that you want to share with the patient, it's a really cool thing for the patient patient to just glance over. Now, you may also then in the future use some of this material for teaching or sharing or mentoring. So what you end up doing is you build this like body of evidence of all your cases or all these complications that are going to be useful for patient communication, but also something that you could share to the greater world one day. And so I love that. And so a couple of examples I give you is maybe you were too ambitious one day with a restoration. Your patient really wanted a restoration. They didn't want to pay for an indirect restoration and you fell for it, right? And you agreed to do this 5-surface composite. And it didn't go that smooth that day and you ended up with an open contact because you prioritized the seal and you got a good seal, but you're left with an open contact. And so now you have a photo of the tooth before you restored it, showing what a sorry state this tooth was in, begging for some sort of ceramic or something indirect. And now B, you've got the matrix on, and then C, you've got the final restoration and it's an open contact and you can clearly see that in the photo. Now, can you see the power in bringing up Mrs. Smith and saying, Mrs. Smith, look, your tooth ideally would benefit from something made outside the mouth. We call this indirect. It's not only going to be stronger, but it's going to be a better shape. Let me show you why. This is what can happen when you really twist and bend the rules and you try to do something as a giant filling, but there comes a point whereby this restoration that we do, this composite, is just too big and it's not predictable. There are too many compromises, and in this case, as you can see, there's an open contact. What this would mean for you, Mrs. Smith, is food packing. Food would keep getting stuck. You'd be forever flossing in there. I'm not saying this is definitely going to happen, but the more surfaces are involved, the more a tooth would benefit from something that's made outside the mouth. And so for here's a crown we did, or here's an overlay we did, and you can see we managed to achieve a nice tight contact. This is why, in your case, it is beyond a restoration. Direct restorations are what we reserve for these teeth. And then you show your other slides where you got lovely class 2s, which are appropriate and maybe not too ambitious. You see what I mean? You get to tell a story, you get to make this consultation a bit more visual, and pictures are of course worth 1,000 words, right? There's no point you explaining that, oh, I don't recommend this because you're going to get an open contact. Showing them a photo and in that sort of PowerPoint and Keynote way is just a genius idea. So immediately I will be converting my folder of all my goodies and photos and before and afters, and week by week building my Keynote, which I can use for my teaching material for you guys and for my patients. So please, please, please implement this if you're not already. And remember, to know and not to do is not to know. Now that you know this thing, and if you agree that's a good idea, if you ignore it and don't take action, you might as well not have heard this part. And so what a waste. So hat tip or turban tip to Dr. Michael Melkers for sharing that on Bulletproof, and I'm sharing it with you guys. Before you now join this main episode full of these 10 exciting pearls, I'm going to give one plug to our course Bulletproof because we've got one date left this year. That's June 26th, 27th. It's in London Heathrow. We've had delegates from US, Australia, Libya, France, Estonia, Slovenia most recently, and even Scunthorpe. So if you want to move away from this abstract thing called occlusion, move towards systems and protocols and real world occlusion that you're going to implement day by day and give you more control and confidence. And we truly believe this is the course you should do before any implant training, any sort of injection molding training, because you need to get the occlusion, because you need to understand the foundations and rules of occlusion that we'll break down for you at Bulletproof. So please check out bulletproofdentistry.com. That's bulletproofdentistry.com. Click on the link below to join us. Now let's join the main episode and I'll catch you in the outro. Dr. Mahmoud Ibrahim, welcome back, my brother from another mother. Occlusion, our favorite thing, right? Today's episode is a funny one. I messaged you, I said, let's do something like really cool. Like, let's talk about some things that we're not going to discuss pre-hand, right? But just some things that you learn in your occlusion journey that helped you make sense of occlusion, right? And at various points in your journey, you can give some context, but it could be a sentence, it could be a tool, it could be anything that really helped you, and I would love to explore that with you today. But for those of us anyone who hasn't listened to the very many episodes that we have done together on occlusion and so much more, occlusion and beyond, I was going to say. For those who don't know, Mahmoud and I teach together occlusion in person and online, and these are always so much more fun to do. We love this kind of stuff, right? The way we met was through our love of occlusion, and it continues. So, but there are some people who haven't seen your stunning
years
work.
Ago now.
I know, right?
Scary amount of years ago now. Just need to think about it.
But
Can I say that one of the tools that helped me is you?
You calling me a tool?
I call you a tool.
You just call me a tool, man.
this time of night, yeah. One of the best tools ever found. It is called
backhand compliment I received in my life.
Hey, look, just take whatever you can get these days.
Yeah.
Okay. Just fact. So thanks, man. You know, I love coming on here and chewing the fat. Is it the fat that you chew?
Yeah.
Chewing the fat with you. It doesn't matter what the topic it is, it's going to be fun. But occlusion obviously is our baby. It's something we've grown together over for many years now. The idea of this podcast was really interesting, and I'll tell you that I actually initially struggled to think of,
How many did I even
occlusal.
tell you to think of? I forgot how many I told you.
You didn't really say a number. Like it was,
How many?
like 3, 5,
so I've got my
whatever.
list in front of me, right?
Listen,
So how many have you got?
I've got about 5.
Me
I've got
too.
like 5.
I bet one of them are definitely the same. I bet you've got like there's one I'm looking at
100%.
right now. I definitely think you've got that one. The other 4, probably not.
Okay, well, that'll make it even more fun. But I'll tell you what, I struggled. I struggled to come up with, because I think the initial thing was like things that blow your mind, right? And I struggled not, and please, nobody think that it's like he's just showing off, none of this stuff is all mundane and blah, blah, blah. And it's actually not that at all. It's the complete opposite. And it's the fact that there was every once in a while, I went on a course, or I spoke to a mentor, or I spoke to a friend, or I spoke to a delegate, or I spoke to somebody, or I treated a case, and something just clicked. Some small detail finally made sense. And they happen, and it's not like a once in a while, and it's like a big boom, but it was just like everything takes time, and something will make it click for you. And that happens over and over, and it still happens to this day. So I kind of struggled to find like what is the big like wow moment. But I'm hoping I've got a few that are interesting, and there are things that really I still think about to this day. I'm like, wow, that really does change things a lot.
I love it. And it reminds me a little bit of just this weekend gone, we were teaching in Birmingham. Dear friend and mentor Michael Melkers had a little stint with us as well. So it's great to have him over from the States. And he said something that me and you look like, we kind of looked at each other like, hey, he's right, man. And what he said was that as educators, right, like we forget our own journey and how many years it took us to learn this stuff, right? And how many different experiences we had, how many different courses we had to go on for it to finally click. But as educators, we want to shorten our students' journey to as much as possible. And maybe that's unfair.
Yeah, the way he said it was amazing, because he said
He
it
always
as
says it more
it's
elegantly
both
than
a
we do.
blessing. He does, right? Like, he's just got away with words, and it's like, yeah, it was called both it's our calling, but it's also our curse. You're trying to really accelerate that learning, and you know what? Sometimes things just take time to percolate, and you need to see it this way and that way, and maybe in 6 months, maybe after you've seen a couple of cases, and things will just make sense. And that was definitely my journey. Definitely.
Well, let's get to it, man. You've got 5, I've got 5. Go with. I want you
Should
to
we
go
do
with
rock,
the
paper,
one.
scissors and see who goes first?
No, let's do this. Go with the one that you think I could have as well. Go with something that you think that I could have.
Okay.
I'll let you go first.
Facially generated treatment planning.
Okay, cool. I don't
Now,
have
I know
that one.
I know people might think, oh, well, what's that got to do with occlusion? But honestly, occlusion, if it isn't part of your treatment planning, then what is the point? Why does it even exist? Right? We changed
Do you mean
the
aesthetics?
name.
Do you mean aesthetics?
Well,
If
no,
aesthetics,
because, well, the thing is, like, whenever, like, facially generated treatment planning unlocked treatment planning for me, and it showed me where occlusion belongs in that sequence. Because, again, the way I was taught occlusion was you look at the teeth, right, and you figure out how they fit together, and maybe it'll look good at the end. But that's not how we operate, right? It's you always figure out where the teeth need to go, and that's usually going to be the upper teeth. So we set the upper teeth for aesthetics. And then that kind of simplifies things a little bit, because all you're then thinking about is how do I jiggle the lower teeth, to move them around, to shorten them, to lengthen them, to whatever, to make it fit that ideal of aesthetics. So to me, that really unlocked the ability to take what looks like initially a complex case, because you're thinking, was it endo? Is it ortho? How many teeth do I need to do? Do I need to bleach? What about the occlusion? Am I going to open the video? And the occlusion questions become just part of this torrent of questions going in your head, and you don't know where to start. Whereas when I discovered facial generated treatment planning as taught by Dr. Spear, it really helped me focus and have a first step, right? Because when you have a first step, as long as you know what that first step is, you can figure out the next one. So that really helped me in my self-occlusal journey to put occlusion where it belongs within that sequence of treatment planning.
I like that
Is
one
that
very
something
much.
that's definitely not on your list?
It's not my, I mean, it is now, but like, do you see what I mean? Like there could have been 100, there could have been 100 things, to be honest with you. It's just, you know, if I woke up a different day and I wrote this list a different day, it would have looked different, right? And that was
100%.
definitely, that easily could have been on there. It wasn't, but easy could have been on there. But it reminds me of when I was in, I think, DCT2 in Sheffield, and one of my consultants, we were doing a case together, it was a hypodontia case, and I was like, how do I know? And I was like, how do I know where to put the smile? Basically, he was like, how do you make this work in this patient's smile, right? And he just said, just start with the centrals. Everything else just work out, right? And essentially, that is the meat and potatoes of facially generated treatment planning, right? It begins, okay, we decide where the centrals are, and everything else will take its place. And that was my way of kind of learning FGPT. But then when I was exposed to Frank Spear's stuff, and yeah, that, you know, that made it so much clearer. So that's a great one. Okay, so the second one we're going to go for then is something that I actually, we were sat together when Kostas Korogenopoulos brought this sentence up, and I probably read it somewhere before, but for some reason it hit differently on that day when I was sat next to you. I think it was tubules. And I think he quoted Dr. Peter Dawson, right? And probably Peter got it from someone else, who knows, right? So
can I guess? Because I think I know.
Yeah, go on.
I guess if teeth are worn and they are in occlusion, they're in the wrong place.
That's it, right? That's spot on, right? So worn teeth in occlusion are by definition in the wrong position. Okay,
He was quoting Spear, by the way.
Was he? Okay. Well, Frank was probably quoting, Peter Dawson was probably quoting, you know.
Exactly.
This is how it works, right? Okay, well, there we are. Double mention of Frank Spear already, and rightfully so in an occlusion-based episode. Okay, this is awesome.
Absolutely.
And so just for our younger colleagues, because one thing that Kostas also said, right, when he put this up on the lecture, is that I hope you guys are able to understand what this sentence means much quicker than I was able to, right? So what you're trying to say is that it took him years to really, truly understand what it meant. So in true calling and curse fashion, let's try and spend 1 minute to make sure every single person understands what we're talking about, right? And for me, the best example of this is that kind of patient who's kind of class 3, like incisors are like class 3, like class 1, borderline class 3, but then there's one lower incisor which is just slightly more proclined, and because of that the upper central incisor is like half the size of the other incisor, right? And so you look at it and you know that by definition this is a tooth position problem. That central would not have been that destroyed or that in bad of a state had that lower central been in a better position, i.e. more lingual alongside all the other incisors. That's one example. The other one would be something that you see a lot of and you've got loads of cases for, which is the very deep bite patient who, when you look palatally, the tooth is just bombed out, right? And the lower incisors sit right behind the uppers, like a wall that you describe it in the wall contact on our courses, right? And I love that. And so that's another example of the lower incisors being where the upper palatal enamel wanted to be, but it can't be now because the lower incisors occupy that space. So why is that important? Is because it kind of tells you what you need to do to fix it, and very often that will involve orthodontics. And so orthodontics is often needed here. And so, yes, there might be a reason to open the vertical dimension. There might be a reason to do, shave something or adjust the height of something. But really, if it's a tooth position problem by definition, then that's what's causing the wear. Then you really need to fix the tooth position through any means, surgery, ortho, whatever you do. But you need to really pay close attention to that.
And I love how you describe this specifically on our course as well. You talk about, think of things as a tooth position problem, as contact time problem or contact force problem. And I think that's a wonderful way of summarizing how wear can be a consequence of 1, 2, or even all 3 things. And the one other example I want to add is it's kind of just a tack onto what you said, but I think people can really start to notice this from like Monday morning, is when you see a patient with wear, have a look at the gingival levels of the lower incisors compared to the lower canines. And often, if you see the lower incisors with heavy wear on the edges, you'll find that their gingival levels are higher, more coronal than the canines. And that is telling you that those teeth have over-erupted. And often, the treatment space required can be gained by just putting them back where their gingival levels tell you that they belong. And that creates the occlusal room. So absolutely, worn teeth in occlusion are often in the wrong place. Put them in the right place, a lot of the time you've got your treatment plan.
Beautiful. That's 2 done, and we haven't clashed yet. So number 3, sir.
Okay. This one did actually surprise me, and I don't know if you're going to have this one, but you kind of helped open my eyes to this one, and that is digital bite scans are not 100% accurate. So for me, this was like, it was a bit of a shock because I thought, okay, well, you can make me a crown margin that is within like 50 microns, looks closed. I can't detect anything with a probe, etc. And yet you're telling me that when the lab tech gets this bite record that I've just scanned, it is not identical to what's in the mouth. And in fact, it's possibly not even as accurate as a silicon bite reg that's been trimmed properly. And so much so that some company, shout out to Bitefinder.
Bitefinder, yeah.
They've managed to create an algorithm that uses AI, that uses the wear facets and the position of the teeth to get a more accurate bite. Because you should think, I've just spent 35 grand on this damn scanner, right? Why can it not get the bite right? But it just goes back to first principles where you think, your ability to check with shim and your ability to convey those shim holds to the lab is still important, even in this day of ultrasonic, super duper, high vis tech BS, whatever, and that kind of blew my mind a little bit.
I love that one. Again, that could have easily been on the list as well. How occlusograms are not as accurate we think. So when you use your 3Shape, your iTero, whatever you use, and you do a bite scan, what the technician ends up getting is not the true representation very often of the patient. And so, like you said, shim holds, you need to give your lab shim holds. Now, please can you just break that down for our younger colleagues who may have just don't know what shim is? Like when we ask our delegates, they come on our like bulletproof, which is a bit more foundational. Like we call it foundational, but Michael Melker says that this is actually a really advanced occlusion course. You take them from like nothing to really high up. But like we also think that it depends on who comes. If it's someone who's like really a new grad, they'll take away a lot. But someone who's got like 20, 30 years experience, which we get as well, they take it away completely differently. So we cater for all, but it's about understanding the absolute pillars of occlusion, and using Shimstock is kind of like a really key pillar. So can you please describe what is using shim? Because going back to my initial point, when we ask our delegates, okay, who knows how thick that articulating paper is? Okay, very few hands go up. Okay, probably on average 1 or 2. Who uses shim, routinely, like daily? Okay, again, very few hands come up. Obviously, it changes once they leave the course because their eyes have been opened to the errors and whatnot. And it's such a inexpensive and like for like things that don't cost a lot and have such an outsized return in your practice in terms of getting less need to do adjustments when you fit things, predictability, stability. Shimstock is this 8 microns foil. Please tell us more.
Oh yeah, in terms of bang for buck, Shimstock like kicks the crap out of anything else in surgery. But essentially, it is non-marking, extremely thin Shimstock foil that you put in your Miller's or your mosquito forceps, and that you're not going to mark the teeth with it. I put it in between the patient's teeth and I get the patient to close into their MIP and say bite and hold, and then I just try and pull the Shimstock out. If it pulls out, then that's telling me that there isn't this actual physical contact between the teeth. But if the Shimstock grabs, then we call that a Shimstock hold, and that is telling us that there is an actual contact between the teeth. And you can start to finesse it, and anything in between where there's a little bit of resistance, you can call that a drag. So you imagine you've now got 3 data points of no hold, drag, hold, all within 8 microns. Imagine how accurate you become when you can tell your technician, this tooth holds, this tooth drags, this tooth over here doesn't hold, and you just give them a few, they're able to calibrate their scans in such a way that your crown onlay, to not offend all the biomimetic folk out there, is dead right in MIP at least, right? It makes your adjustment time so minuscule.
So the way that helps technician is that they're able to verify what the occlusogram that you sent with the shim hold, and actually, verify or even digitally manipulate the models, a bit like using Bitefinder or doing it by eye to correlate to the shim holds basically. So absolutely fundamental, and I'm glad you mentioned that one. So that's good. So that's 3 done. 4th one I'm going to say is something that Michael Melker's taught us both, is when you're doing a restoration, let's say you're doing on the left side, okay, obviously you're going to check your occlusion pre-op. Like that was an easy one. We could have easily made that one.
You love this one.
I know, right? So we could have easily made this one like a separate one whereby please check the occlusion before the restoration. Like that could have been one, but I thought that was too easy. So the one I picked is, okay, once you've done your restoration, instead of like classically you want to pick up the color paper and check the side, check your restoration, but really you should check the contralateral side, right? You check the contralateral side and then you pull. And if it pulls through, well, you're at least that thickness out. So for example, let's say we're using a 40 micron paper. Okay, I like Parkel, it's like 21, 25 microns, right? But let's say 40 microns, and it pulls through. Well, already, before even checking the actual restoration, A, you're proud, because that should have been holding, and B, you're proud by at least 40 microns. And so you get some data, and then you can double it up and do 80, and then, okay, now that's holding. So mathematically, you're somewhere between 40 and 80 microns proud, and that just helps you to know which grit diamond burr to pick up, and how hard to press, and how generally how purposeful you should be, so you're not wasting time, you're being more efficient. So that for me was really a really good way to bring maths into figuring out how much I need to drill.
You bring the math, I'll bring the physics, man. Yeah, I mean, for younger grads, for people who aren't used to sort of this concept, it might sound like, come on guys, I can't tell the difference between 40 and 80 microns by eye. Like, I don't know how, but if you think about it, we know that if you pick up a red diamond, that's what 40 micron diamond, right? If we know our red diamond is somewhere, it depends on the manufacturer and stuff, but call it 40 to 50 microns, right? That a couple of passes with that will probably be enough. What you're not going to do is you're not going to pick up your white diamond that's like 10 microns and spend half an hour trying to drill the thing away. So with experience, that becomes valuable information. It's not going to be something that's like automatic and intuitive, but with experience, you'll know that, when I've got 80 on the other side, I'm spending a little bit more time, I'm using this burr or whatever. And with practice, it's a really, really neat little time-saving tool.
Great, I'm glad you're in agreement. That's 4 done. Over to you again, sir.
Okay, are you ready to get a little bit more advanced? Just a little bit more in the weeds?
This is the perfect point.
Okay. So the first movement of opening is not a pure rotation. Now, you know how much I love this one. And where this really sort of like unlocked my brain was when I was trying to think of the whole envelope of function thing. We have plenty of mentors out there, like including Tiff Qureshi, including Mike, Lane, and everyone talks about the envelope of function. And the first time I heard the term envelope of function, I was actually reading Pete Dawson's book, and it was the anterior guidance should be in harmony with the envelope of function. And I couldn't figure out what the hell that was supposed to mean, I'll be honest with you. But once I understood that the lower incisor will not open straight down, because we do not open on a hinge. They tell you that the first 20 millimeters of opening is rotation, and then after that, it's translation. That's what you learn at dental school. And that is a way of explaining the capacity of the joint. So essentially, your TM joint, it can rotate in place open 20-25 millimeters. But when it is left to the muscles that act on it, that never happens. You never get independent rotation and then translation. They both happen simultaneously. And what you got to remember is when the jaw opens, your lateral pterygoids contract. So if your lateral pterygoids contract, even a tiny bit, immediately your condyle is going to translate. So what does that mean? That means that goes back to the whole wall contact thing. If you do ortho or you do your restorative dentistry and you create a wall, and by a wall I mean a contact on the anterior teeth that isn't a point, but it's a wall, a surface to surface contact, there is no way for that lower incisor to move without some rubbing happening. And that's then when you see your orthodontics relapse, your retainer fracture, your teeth, or the teeth wear, or they become sensitive, or whatever.
Or the joint, breaks down, takes too much load.
Of course, yeah. Or the muscles, or whatever.
Hello, YouTube Protrusive. I know you're watching on YouTube, and I hope you're enjoying this episode so far. But I wanted to highlight, in case you don't know yet, we have an amazing viewing experience on protrusive.app, our website, our network, our platform. So I just want to spend a minute to show you what this looks like. On the left side, you see the navigation, and when you join the app, you get a 1-minute video tour of the entire network. Now, in terms of where the magic happens, that's in the Protrusive community, because you might come for the content, but you'll stay for the community of the nicest and geekiest dentists in the world. We have all these polls, we have a chat group, there's always active chats and dentists helping dentists. And really what I want to do is create a really supportive environment that's not like the environment we have on Facebook, and it's built on the values of niceness and geekiness. If you are nice and geeky, you belong here. Now, to make this a safe space, we have a manual process of approval. We actually verify that you are a dental professional before you get in here. So we have hundreds of applicants a day. So if it's been about 2 days and you haven't heard anything, either something's in your junk or you need to reach out. If you're still waiting to join your tribe, email marie@protrusive.co.uk. That's MARI@protrusive.co.uk, and she'll investigate what's happened. Now, all the videos you have on YouTube are also on here, but you actually have some extra ones for free that you don't have on YouTube. So you get some bonus content that's not on YouTube. And actually for the future, I'm not taking things out of YouTube, but some things are not appropriate for the wider public, and I want to sort of safeguard that information, which is like dentist talk, if you like. So that's why a lot of the content is only here and not on YouTube. So you're kind of missing out if you're not on here. That's why I'd love for you to join there. And if you join one of our paid plans, then what you get is access to the CE quiz, like this one, and you can get CPD or CE certificates, and also you get our premium notes. So these are a great aid memoir or revision for an episode to really cement your learning. And whilst we have ads and YouTube places ads on YouTube, we don't have that on our network. So for the paid plan, you get to see all of the premium notes without any of the ads. And of course, you get to support Team Protrusive and help us to continue what we're doing. I'm just going to gloss over the Protrusive Vault, which has all our infographics and downloadables. These are all our masterclasses at this moment in time, and we're always planning to add more. And if you look at them, there's about 1, 2, 3, it's about 7 of them. But actually, if you look at the replay section, some of the live masterclasses that I've done and some of the training that people pay for on other websites is all on there, included as part of the masterclass subscription. And if you're a student, don't fear, we have a special section for you with all the student notes, which anyone can access. So for example, here is one on exodontia. So it's all there waiting for you on Protrusive guidance. Please head over to the website, which is protrusive.app. Make an account on your browser. This could be Safari, Chrome, however you want to do it. And once you've made your login, then you can download the iOS or Android app and then log in through there. So the reason to make the subscription primarily on the website first is that you get access to a free trial, which you don't get if you make an account on Android, iOS. If you make it on the website, you get access to the free trial, and you get our best price if you sign up through protrusive.app. So our best deals and free trials are only on protrusive.app. Of course, we always put the link below in the description, and thank you so much for enjoying our videos on YouTube. But it's now finally time to level up your experience. Back to the episode.
The system is designed for the lower incisors to have a little bit of room to move. It is historically being called long-centric or freedom-incentric, or some people say, actually, you just didn't get CR right. If you get CR right, if your technique wasn't sloppy and you didn't suck and you got CR in exactly the right spot, you would get this hinge and you don't need freedom-incentric. Only wusses need freedom-incentric, but it's just not true. All right, it's the physiology, the anatomy, the way our muscles and joints work means the lower incisor just needs a little bit of room to move. And the whole thing of saying it needs to be in harmony with the anterior guidance needs to be in harmony with this. It means that the anterior guidance needs to be steep enough to disclude the back teeth, but shallow enough to allow the lower incisor room to move without bumping.
Yep, elegantly said.
In a nutshell. So that, for me, was like a real light bulb moment.
I love it. Very good. No, that's a good one. I'm going to go for number 6 then. This one I really love, right? I think this one's inspired probably by something Riaz Yar said, and I went away and I thought about it and I saw it in practice, and it really then it became like a really good gem, especially in the TMD clinic, is that in a healthy occlusion, a patient, when you bite together, Mahmood, when you in a healthy occlusion, your muscles should contract on both sides symmetrically in coordinated fashion. For example, your masters should fire at the same time, and pretty much, we can call it 100% contraction, but it won't, because there's PDL, there's a central nervous system will not allow you to contract 100%. If there's like a really hard, a frozen gummy bear in there, then you want to crush it, then yes, your muscles will allow you, your CNS will allow you to do that. But on your teeth, you'll get to maybe...
a nut. What the hell is a frozen gummy bear toothless?
It's just always in my mind, because I remember my son he went to Cold Stone Break, that Cold Stone ice cream place, right?
Oh, okay.
And he always picks gummy bears, right? And
I see these soft gummy bears become like rock solid. I'm like, well, how are you eating that, right? Anyway, that's what comes to my mind when I think of something hard nowadays, right? A frozen gummy bear. Anyway, so on our teeth, we're not, whilst we can't go 100%, we go most of the way there, right? 80%, let's say. But the main thing is our muscles, when you feel the insertion of the masseter area, so near by the angle of the mandible, you feel the bulge of your masseters. And A, you should feel a healthy bulge, right? And B, they should be perfectly in sync. And even more so for the anterior temporalis, right? Above and distal to your eyebrows, feel that, clench, clench, clench. You feel your temporalis muscles, and they should be very even in contraction. If they are not, it's a sign that something is off. The bite is off, there's some sort of dysfunction, or your muscles are not wanting to fire because they're worried that the joint's going to suffer, or the muscle is going to feel some sort of strain, so they just choose not to fire. Very often, if something is proud on the left, right, and it's been a few days, okay, immediately, if something's proud on the left, yes, the left side muscles do fire, usually. But an adaptation happens often a few days later, whereby now, if something's proud on the left, let's say you fit a crown, and it's on the left, and now the only thing touching is that crown on the left, and the patient goes home, a week later, they come back. If it's still proud, the right-hand side temporalis will be firing, not the left side, right? The wrong side, the opposite side, okay? Because the left side muscle has no need to contract because those teeth are already touching. Or the nerve saying that, hey, we're already doing, teeth are already touching, we don't need to fire here. So it's the contralateral side that fires. And when you start, why is this even important in day-to-day practice? It's another data point, right? When we're checking that restorations are healthy and perfect or post-orthodontic result, not only am I checking shim or fremitus with our fingers or how it sounds, but the muscles as well. We need a nice, healthy clench. And so if I'm able to achieve that on an occlusal appliance or on my rehab, then that is a good sign and it shows good adaptation to the new occlusion.
I love that because every time you demonstrate that on the courses, you'll have someone in the chair and sometimes you'll spot these discrepancies and then you'll get them to put cotton roll in on the side.
On both sides.
On both sides, and then you get the symmetric contraction. That I think is quite like eye-opening. That is pretty cool because another thing you say on the course, and I love this, is whenever you're talking to dentists and saying about, have you done an occlusal exam? Yes. Have you checked the muscles? Like, what have you checked? That they exist. It's like, so, if you don't palpate enough muscles, you can't even tell whether they're hypertrophic or not, right? You got to get the reps in just to be aware of what is normal. And when you were saying that if it's high on say the left, this is my left, if it's high on the left, a couple of days later, the left temporalis will no longer contract as much. Is that also maybe like a protective function where if it contracts, it's overloading a high restoration? So it's kind of like protecting itself.
Protecting, but B, the mission of the contrast side is, well, I'm not touching, how can I touch? And so the muscles contract to try and bring the mandible higher up to create contact, right? And so that's what it's trying to do. If dentists are not used to doing this, then look at your patient in the middle of Invisalign, right? Like literally right in the middle of Invisalign. Get them to take off their aligners, feel their muscles. Very often they'll be all over the place, right? But at the end, once everything settles over and the tooth position is settled, then the muscles are working in harmony again. Now, in my general patients, I would say 95% of patients absolutely have a healthy clench, healthy musculature, quote unquote, good bite in that sense. Whilst their bite may be messed up, the muscles are happy with it. They're able to contract. But in my TMD clinic, I would say that only 40% of my patients in my TMD clinic have actually got healthy, sound muscles. So it's got a huge player in the TMD clinic.
I would imagine, if you're getting myofascial pain, you're getting headaches, there must be a relationship in at least some patients, right?
There are 2 patients I can think of at least where I'm just not able to get any sort of contraction, even on cotton rolls, right? Like I'm just nothing at all. Okay. And so I was reading more into it, and possibly it's a central nervous sensitization. It got so used to not contracting anymore that actually it's lost the power, the ability to contract.
Wow. Okay. That sounds like a pretty extreme case.
Yeah. Sorry, I shouldn't have probably gone so deep there.
Oh, no.
The main lesson for everyone listening is A, when you're palpating the muscles, don't just press them like lymph nodes, right? Don't just feel that they're there and move on. You know, actually get the patient to bite together, feel the might of those muscles, feel the size of those muscles, because they inform your occlusal risk. And you also get some information on the general health of the occlusion. Occlusion health, one of the ways we measure occlusal health is there a healthy clench? Are the muscles firing in harmony, in coordination?
I love it. It's all the system, right? You're going to check all parts of the system.
All right, over to you, sir, number 7. We haven't clashed yet. We haven't had a single repetition. I'd be amazed if you get through the whole thing to 10.
Okay, let's see. Okay, this is not strictly an occlusal as such, like lesson or point I read in a book, but it's something that we often say on our courses, specifically because people tend to focus on the tooth they are treating, right? Doing an onlay on this upper left first molar, that is where I'm focused. But it takes 2 to tango. Occlusion doesn't work if you don't have an opposing number. So I urge everyone to always make sure that when you're doing your pre-treatment assessment, so you're going to place an indirect restoration on a tooth, you're going to do your vitality test, you're going to take an x-ray, check the occlusion, so check where the occlusal marks are, check the shim holes, also have a look at the tooth below, right? What if it has a really big pointy cusp? No, do I want to give this away? Actually, no. It's always fun to do on the courses, so I'm not going to. But always look, right? If the opposing tooth has a really big, tall, sharp cusp, right? Do you really want to leave that to enact its wrath upon your ceramics? Which, if you then underprepare your tooth, you've got a thin bit of ceramic, and now that sharp piece is just going to traumatize it and eventually lead to a crack or a fracture. So again, it's like always look at the opposing when you're assessing where. Look at the opposing. When you're assessing occlusal space, look at the opposing. But just when you're thinking about adding some composite, for example, to some upper edges, yeah, and you're going to make all these like pretty effects, look at what's going to be acting on them on the bottom. If that isn't kind to your restorations, then you need to do something about it. It's always better to be able to explain this to the patient before you've done the treatment.
You say that so much on the course that it takes 2 to tango. And yeah, I mean, we appreciate that. I think it's a good, very, very good reminder. I think this is number 8, 9, 10. Yeah, I think it's number 8 now. Anyway, I've got 2 left, basically. So this one, the next 2, so the first 3 I did was worn teeth in occlusion are by definition in the wrong position. Then I did check the contralateral side and use some maths. Then I did the muscles, right? Now these next 2 I did because now you may need to purchase something. And so I kept the first 3 like, okay, you know what? You just need your fingers and your eyes and your senses and your brain. These 2, you're going to have to purchase something, okay? So number 8 for me is a leaf gauge. When I started to use a leaf gauge, it was like, wow, you know, because I had been on so many occlusion courses and bimanual was unpredictable for me. Maybe I suck, okay? But bimanual was predictable. The mandible was very often rock solid. Then the deprogramming, and it's not that I couldn't take a registration, it's that in my heart of hearts I wasn't confident that I did achieve a muscular release or I was able to get to CR, and so there was so much doubt. But when I learnt the leaf gauge, and then so much of that was taught by Michael Melkers as well, and he really helped me to refine my protocols with the leaf gauge, it became so much easier. I was able to move forward with my cases to the next stage because I was a bit more confident that, okay, you know what, if we're not there 100%, we're like 98% there now, and then you can go, right? And something that Ian Buckle says, I'll quote him, is, CR is like playing golf, right? You're not going to get a hole in one. You're going to get a little bit closer and a little bit closer. And what the leaf gauge did was, it was getting on now. I don't play golf, but is it getting on the green? Is that a good thing?
You're asking me, dude? I have no idea.
Man, we're the worst people,
Unless
right?
you're putting a ball in a basket, I don't know anything about sport.
You're getting in that bit near the flag where the grass is shaded a little bit different color to the rest of the grass.
I'm sure that's good. Yeah, I'm sure that's the point. I don't know.
I've been watching Ted Lasso recently, right? And I sound like Ted Lasso. You know, when he comes from America, he's like he's coaching football, and now I've just explained golf.
You have explained so many things in Ted Lasso terms over the last couple of weeks.
Like, because the only thing
so
I watch
obvious
now.
that you're watching.
It's the only thing I get time to watch. Anyway, the leaf gauge. The leaf gauge is a wonderful thing. It's basically this plastic. In fact, you explain it so well on the course. You take over.
Okay, essentially, it is a bunch of plastic leaves each. If you take 10 of them and stack them, you've got a thickness of about 1 millimeter, let's say. But the beauty of it is you can add leaves or take away leaves to make this gauge as thick or as thin as you want. And it's just a flat bunch, and you get to put them between the front teeth of the patient and get the patient to sort of slide forward and back and squeeze. And the idea is that you're removing the influence of the back teeth on the bite. And to try and really cut long story short,
It's like it's like an instant Lucio jig when you stick the leaf gauge in.
Yeah, essentially it's a flexible form of Lucio jig that you can make it thicker and thinner on demand, and just like that. Like you said, it provides you that stepping stone that gives you confidence that you have reached a position that is somewhere near CR, right? And like you said, you can move ahead with treatment planning the case. And this is a lovely segue into my next one, which is number 9. I think it's number 9. So, because that quote that you mentioned from was it
Ian Buckle?
Ian Buckle. Sorry, it's late. Okay, was that he said that even if you're not 100% at CR, right? It's a game of golf. We're gonna get closer with every step. And what he meant was, step 1 is maybe the wax up. Step 2 is maybe you're doing the preps and you're putting the provisionals on and you're equilibrating or adjusting the provisionals using what? Guess what? The leaf gauge again. So actually my number 9 is the importance of provisionals. And this was kind of like the leaf gauge for me because it was a huge, huge unlock when it came to the fear of taking on complex cases. Because I just looked at these cases where the teeth were worn and broken and chipped, and these dentists would open the vertical dimension, design a whole new aesthetic, a whole new occlusion, and they would put everything in and it would work. And I'm like, but how do you know it's going to work? How do you know? How do you know before you've committed, right? And that scared me. And that stops you from moving forward. And then it was again, we're just quoting people here, which is great because this is what happens, right? Again, it was Dr. Frank Spear that openly and honestly just said, how do you know it's going to work? You don't, right? You don't until you try. And when one of the best dentists in the world looks you in the eye and says, you don't know, you're like, okay, well, if they can't know, then I can't know until I try. And the key is you need to get provisionals. Now, obviously, the planning beforehand is really, really important. So I'm not saying, it's just work it out in the provisionals, but you do work it out in the provisionals. And you won't know whether your occlusal plan is going to actually work until you try it. And that's the value of provisionals, that you can then adjust, you can lengthen, you can shorten, you can adjust the opposing. And only when it works in the provisional do you then transfer that design into your final restorations. So if you are out there and you are scared of taking on complex cases, just remember that you will not move from treatment planning to putting a burr to a tooth until you have a wax up and you've done a mock-up. That keeps you safe because you know that the aesthetics will work. And then you will not move from your provisionals to your finals until you've had the provisionals on long enough that you know that the patient hasn't broken or chipped anything. That will again keep you safe. And if you know that you're not going to jump to the next step without the first one working, then you probably, hopefully, won't get yourself in too much trouble.
Excellent. And just to add on to provisionals, you know how we look at crowns that are linked together and we think, oh, that's really bad, they shouldn't link crowns. And occasionally, as part of your force management, you may actually do that, believe it or not. But when it comes to provisionals, when I started to consume more of the lessons of comprehensive dentistry and saw all these prosthodontists linking provisionals in the sort of provisional phase, I was like, oh, great, you can do that. It's okay, right? And I was like, okay, fine, it's cleansable. Okay, fine, it's okay to do kind of thing. And it's now and again, I'll show a newbie dentist is like, hey, you can do that? You're allowed to do that? So yes, when it comes in provisional phase, you're allowed to do that. So that helped me to understand things as well. I'm surprised you didn't say leaf gauge. That was the one I thought we'd clash on or have the same one. But there we are. We managed to get 210. The number in this podcast is always going to be,
I think we're at 9.
Dependent. Yeah, but now I'm gonna give the 10th
You're
one.
gonna
Right?
give one. Okay. Yes.
And then we got 10. So I thought we were gonna get maybe 8 or 7 because I thought we'd have like some of the same.
Good.
So
Good.
wow, this is pretty
Amazing.
cool. Okay, so the
Amazing.
next one you had to spend a bit more money to get, and it's a T-scan, right? So the T-scan for what was this? The realization was when I went to one of Rob Kursian's lectures, and there's this thing whereby if I show you a photo of a quadrant, right, and you've just done these quadrants of onlays and composites, and you use your red Arctic paper, tap, 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 and you look at that, and the patient says, it's proud, right? And then you look at the markings, and you're trying to basically guess where it's proud. And if you look at the markings and you try and guess where you're proud, you'll only be correct 12% of the time. Because I didn't realize at that stage that there was actually very little correlation between what the ink looks like and how much force is going down the tooth. Now, there are people say, yes, you have to look for the bullseye, or you have to look for in fact, the smaller point because the smaller one's higher force, or the bigger area, whatever it is. But actually, that's quite poorly correlated in the literature when they do these studies. And so when I realized that, That was really interesting. Now, I have to say to you, I was always quite skeptical before I got a T-scan, because me and you, we check fremitus. We use our fingers, check fremitus. That's a data point. We check with shim, right? So I was always thinking, well, if I'm in that scenario where I've just done a quadrant and something's proud, well, the first thing I do is isolate the tooth using shim. Sometimes if your shim is thin enough, you can actually isolate, okay, which contact is it? But ultimately, when you're doing more comprehensive dentistry, to have something like a T-scan has been brilliant for me, just to get more data, right? Just be geeky about it, get more data, and just be quicker at my decision making and more confident. And also, now that I've been seeing TMD patients, I've attracted some interesting patients with interesting occlusions, or actually interesting perceptions of occlusion, right? How they perceive their occlusion. And now that I have objective data, I don't have to be at the mercy of a patient say, oh, but can you just do this one a bit more? If my muscles are happy, if my shim holds are good, and now I've also got a computer telling me I'm good, that's my end stop now, right? That's my,
and you can show them, I guess, right?
Exactly.
That's the beauty of it as well.
And with that, and the last thing I'll say with that is equilibration, right? I was always scared about equilibration, always, because I'm like, how can you move tooth structure, and then what if what if they get worse or don't get better, right? With the T-scan, I can be in a situation where I can see that the occlusion is 80% one side, 20% one side, right? Whilst they may not feel better, I'm not saying it's actually nothing to do with the percentage either side, whether they'll get better or not, but I'm just giving you an example. Whether their perception of their bite, for example, or how even everything feels. Even if they say it doesn't feel better and something medical legal happens and they say, but the patient said this, I can say that, look, I genuinely took someone with a very rubbish bite to a very good bite. Here's the objective data of the quality of this person's occlusion. I'm sorry that they did not get better, but I did everything I could. And that for me was, I felt much safer having this data.
The more data, the better, always. Well, mostly always, as long as you know what to do with it. And your point about the medical legal cover is a huge one. I think, if I had to choose, like if someone put a gun to my head and said, you have to buy one, either the module or the T-scan, I'd get the T-scan. I think at this point in my career, in terms of what I would get the most actual value out of, it would probably be the T-scan. I don't know if you made that decision, if you had that thought process yourself, or if it was just you really wanted a T-scan, but I don't know if you'd agree with that.
I would. I mean, that's not to say module isn't brilliant for the data it gives as well, the motion data, right?
Of course.
But yeah, for day-to-day, how I use it and how I use it in the clinic, even for occlusal appliances, right? I use it to just very quickly tell me that, okay, I can see this stabilization splint has 6 dots, but 2 of those dots are taking 70% of the force. Like, the patient can't tell you that, right? You see the 6 dots. I now know which dots to grind heavier on, and it's basically saved me time, right? So a splint fit of like that, to perfect it, usually could have taken me, X amount of time. I've halved that time, or even more, or even quicker, because of that kind of data. So there we are, 10 ways that occlusion started to make more sense for us, and I'm so glad that you had 5 unique ones and I had 5 unique ones. That was fun, even though it's really a late night episode tonight, and my brain is fried because I think it's the 4th episode I'm recording today.
Yeah, I think you did well, man. You did well. You were mostly coherent, apart from the frozen gummy bears.
Yeah, well, I was definitely lucid and coherent when I was thinking about the gummy bears, put it that way. But it's just an interesting thing that, interesting examples people think of, right? And there we are, frozen gummy bears is my hard thing that someone might bite into. Mahmoud, tell us where we can check out your work and the wonderful Instagram profile you have, the most beautiful cases and all the teaching that you do on there as well.
Thank you. Oh, thank you. So my Instagram handle is DRMOI Dental. My Instagram is a bit schizophrenic. It caters to both patients and dentists. I cannot be bothered to have 2 separate ones like you. But I do post some teaching stuff, some just in my cases. My passion lies in occlusion and composite artistry, so it's a meld of those 2 things. Always on Protrusive Guidance, the app. So guys, if you're not on there, what are you doing? It is literally the best place to ask your questions, to chat, to vent, to whatever. It's just awesome. And otherwise, just try and come and join us on one of our courses if you want to learn more. It's even this type of atmosphere. We have fun, we have a good laugh. You do not need to buy a T-scan to do good. I don't have a T-scan. I don't own one. I still do, digital dentistry the old-fashioned way, fremitus, Shimstock, and I still do full mouth rehabs doing that, and people have done so for the past 100 years. But it's once you've got the basics right, you can always elevate. You can always elevate. So yeah.
Super, buddy. And I'll just give us a plug for our courses. 2 main flavors, well, 3 main flavors. One is the online flavor, that's OBAB. The second flavor is Bulletproof. We're thinking of rebranding that one to something as simple as Understand Occlusion, right? The Understand Occlusion course, right? And this is like, we get to fit a posterior crown and discuss quadrants and conformative dentistry and when you should open the vertical dimension, when you shouldn't, hands-on.
Get to
Gone.
leaf gauge. Get to use the figure out the
introduction
leaf
to
gauge finally. Last
joint
tooth in the arch
position.
syndrome.
Yep, risk assessment. So real world occlusion, how you might lose space, how to develop your protocols in tough cases, how to identify which are the tough cases and how to occlusally manage those. And then your favorite passion, the unchippable, which is the composite artistry and the occlusion. And that's, we used to say it's a level up from Bulletproof, but Michael convinces that actually they're both pretty at a high level in terms of complexity, in terms of how, if you think that you want to go on something that's really going to advance you, then they both can do that. But the distinction is with Unchippable, we talk about open the vertical dimension. You actually adjust a case on articulated models that involves opening the vertical dimension, where we just fall shy of that in Bulletproof because we kind of really build the foundations.
Yeah. I really want you to leave, like when we were designing Unchippable, it was like, okay, if things truly, we want to show you the best way to make something unchippable, that has to include managing wear cases and giving you at least the confidence to be able to tackle your first dull case, open the video and create some room and create restorations that can function and parafunction beautifully, as you say. We wanted to get you over the line with that. The pre-course online stuff is a course all in and of itself. It's like, this is 16 hours. So you've pretty much got a full 2-day course.
No, I take it back. It's 18 hours online.
18 hours. It's like 2 full days of learning already before you even show up. And it is because we wanted to get you over that line, right? First day goes long. Second day is not short. It's a ton of value, but it's also a ton of fun.
No, it's definitely one of they're both cool. It's like choosing between children, right? But we love both these. They're very different, but there are lots of similarities as well. And those delegates who've done both will say they enjoyed that crossover. It wasn't too unfamiliar, but it was different enough that they felt like they picked up a lot more in their own way from each course. Mahmood, thanks for this late night session recording. Look forward to getting this one out, and I appreciate you so much, my friend, for geeking out on occlusion with me.
I love it, man. Nothing better.
Thanks for calling me a tool.
And there we have it, guys. I hope you enjoyed those 10 pearls provided by me and Dr. Mahmood Ibrahim. Remember, guys, if you want to join us on our Bulletproof course, head over to bulletproofdentistry.com. That is bulletproofdentistry.com. We do have installment plans available if you like, and the next date is 27th June in Heathrow. It's only around the corner, so secure your date. And that is only around the corner. It's coming thick and fast, so don't delay, because it could be the last one we do this year. # he's got 3 kids, I've got 2 kids. This episode was full of so many nuggets, and it is eligible for CPD or CE credits. We are a PACE approved education provider. If you're watching this in the premium section of the app, scroll down. Thank you so much. Answer the questions, get 80%, and our CPD Queen Marie will send you a certificate in the usual way. And if you're completely new to all this and you'd like to get CE for commuting, and then you don't have to scramble to do CE and CPD at the end of the year, you can enjoy more time with family, head over to www.protrusive.app. Try us for free. Do a 7-day free trial. See what the Protrusiverse is all about. I'm sure you're going to love it. The CE, the community, the master classes, it's all there. So head over to protrusive.app for that. I want to thank Team Protrusive for all their work behind the scenes, and of course you guys for tuning back always. I appreciate you so much. If you found this useful, please share it with a colleague. Oh, and it is Clinical Clarity and Decision Making Month on the podcast this month. And so at the end of this month, we've got 2 absolute banger episodes with a professor in cardiology that many of you know already, and it is just mind-blowing. Like, it's going to give you some definitive protocols nowadays, contemporary management of caries in 2026. What's new? What's different? Don't forget to tune in at the end of this month for those. I'll catch you same time, same place next week. Bye for now.